I go to present a case. It's very different case, but I think it's important to discuss this case because sometimes happen with us what's happened with the girl. It's a 11 years old girl. She was run over by a motorcycle. At the scene, here you can see 1 p.m. At the scene was 1 p.m. and the machine was run over by a motorcycle about 90 kilometers per hour. The injuries that can see only a brain trauma. She was crying, and the treatment at the scene was transferred to the support, the basic health support, and transferred to the basic care unity. She's go to the basic unity only. In the basic unity, there's no information about respiratory rate, saturation, vesicular murmur is present bilaterally, no information about blood pressure or cardiac rate, but she starts here at Glasgow Coma score 12. Then during the assessment, the Glasgow Coma score decreased to 7. And she was noticed that she has an anesocoria, and the people was reagent. She was intubated and mechanical ventilation, was sedated with fentanyl and midazolam, immobilized with a cervical collar on a rigid board, and was called for a transportation by helicopter to our service. At 3:10 p.m., she arrived at our service. During the transportation from the airport to the surgical room, emergency room, she had a cardiac arrest. Her respiratory rate, saturation, she was intubated in mechanical ventilation. Murmurs vesicular present on the right and decreased on the left side. Blood pressure, cardiac rate, fast exam negative. Glasgow Coma score is 3, sedated, intubated, pupillus mediatica pupil. What to do in the situation? Let's go. What you do? A child, 2 hours later, I have a blood trauma, shows Glasgow Coma score in scene 12, and she comes in our hospital. During the transportation, have a cardiac arrest. So what to do?
Dr. Super?
This patient, now she has cardiac arrest at your hospital. I think we should start with CPR. You intubated the patient already. You should start with chest compression. And after 1 cycle, if there's no ROSC, you should decompress chest bilaterally. Maybe put a bilateral chest tube. And while performing chest compression, the other doctor should try to look for possible source of bleeding that is correctable, like performing fast to check for an intra-abdominal bleeding that needs to be operated on. And if you have everything ready for this patient, you may have to perform resuscitative thoracotomy for her if she doesn't respond to chest compression and bilateral chest decompression. Thank you very much.
Thank you, Dr. Super. Let's go to Atlanta, Dr. Frisbee.
Well, I agree with Dr. Super. You know, the first thing I would do in a child like this, I think they have their lines in. I'd make sure that ET tube is where it's supposed to be. Most of the time, these children, their hearts are young, so they're not gonna have a heart attack like we would characterize it. But that's the first thing I would do, and I think I agree with Super for the remainder of the initial treatment. That's all I've got.
Thank you, Dr. Frisbee. Dr. George, your comments, please.
Well, so far, with what everybody else has said, I agree so far. I'm thinking now emergent thoracotomy, which could be life-saving, but it depends on how long she's been in cardiac arrest. I'm not sure. Has it been over 10 minutes? or did she just come into the center and went into cardiac arrest? So I'd be doing CPR, ensuring that the chest tube is correctly placed. Ensuring that the ET tube is correctly placed. I'm thinking here, if I don't have a neurosurgeon in the department in my hospital, that he should be called right away to evaluate a head injury here and start continuing our CPR until we can define more if we get any vitals on her.
Thank you, Dr. George. Toronto, Dr. Ali, your comment, sir? Dr. Ali,
Has she
Toronto?
got any rhythm? Is cardiac arrest, is it related to or there was absolutely, it was asystole and no ventricular activity on the EKG?
Yes.
I see. So I think it's reasonable to open yes.
I'm sorry, Dr. Ali, we're losing your audio. Why don't you try stopping your video? See if you have enough bandwidth for
Unless the time has been tried like this, I think it's worth doing. Yeah.
Okay. Thank you, Dr. Ali. Iraq, Dr. Luntrak, your comments, please.
Yes, I agree with all the previous comments. I think Dr. Frisbee's point about confirming the position in the tracheal tube, since there are no breath sounds on the left side, and especially in children, if the tube is inserted too distally, it'll be centered. The tip will be in the right mainstem bronchus. So we need to check for that. The Dr. Collet reported that the FAST was negative. So I assume that means that there was no pericardial effusion, but I would go also to the extended FAST to look at the chest wall cavities, because it might, if there are no breath sounds on the right side, she might require simply a chest tube to decompress. And so I would check for evidence of a pneumothorax or a massive hemothorax that might be more readily corrected, suppressing the chest. And then the title of, or one of the aims of the presentation is listed as the role of emergency thoracotomy and trauma. And given that this is a child, I think, as several others have said, that this would be probably the exception that proves the rule that in children, it's certainly reasonable to be much more aggressive. As for example, that case of head trauma that had been presented a couple of months ago where the child recovered completely, and it was thought that
did we just lose Dr. Luntrak? No, he's here. Dr. Luntrak, you muted yourself, sir. Okay.
Okay, you can see me now. While I was talking, my screen went blank, but basically I was saying, I think you heard everything up to the point where I was talking about emergency thoracotomy. And I think this, as everyone else has mentioned, this is basically the exception that proves the rule, because children are so much more resilient, and that I would certainly tend to be more aggressive, after first ruling out something that could be corrected with the chest tube on the left side. If a heart rhythm was not recovered, I would certainly consider doing an anterolateral thoracotomy on the left side, simply because children are more resilient. But immediately I would proceed to looking at the chest by ultrasound to determine exactly what might be the cause of the cardiac arrest. And then the neurosurgical trauma depends on the side of which pupil is more dilated. That's the site that needs decompression. But once the circulation has been recovered, then I would try, if possible, to get a rapid, as rapidly as possible, a CT scan, because that'll direct you more precisely. But if you couldn't do that, or there's no CT scan, I would do a burr hole on the side with the blown pupil, the side that had the larger pupil, but that is secondary to recovering a pulse and a blood pressure.
Thank you, sir. Portland, Dr. Kasim, your comments, please.
The immediate problem with this child is cardiac arrest. Rest is all toothpaste. So the algorithm says in a blunt trauma, head injury plus cardiac arrest is a very bad sign, and their survival is almost negligible. Be that may, this is a 12-year-old, and you can't give up so quick. So the first thing I would do, I would put the ultrasound on the heart to see if there is activity. If there is activity, bilateral chest tubes go in by somebody else, and I will do EDT, thoracotomy, anterior thoracotomy, because external cardiac massage will only give you a 20% cardiac output. And it's important to keep the circulation to the brain going, which is already injured. And so you have a lethal, two things going on, two cavity, head cavity as well as the cardiac problems. So I think the only way you can salvage cases like this would be to be extremely aggressive, as my colleague from Iraq says, and never mind what the book says. You need to go for it and don't waste time. Get it done. Open the chest up and do what you can to salvage this case. Thank you.
Thank you, Dr. Kasim. Lima, Peru, Dr. Calderon, your comments, please.
Yes, good morning. We still don't know the reason that this patient is in cardiac arrest. Could be due to the head injury, cardiac injury, any pneumothorax. So yes, the BLS, ACLS has already been initiated. It means checking the pulses, put the patient on a cardiac monitor. Of course, when the patient comes from the outside hospital, another institution, we have to recheck the tube position. I mean the endotracheal tube position, and we have to restart all the ABC again, if possible, because it's very difficult to do the cardiac massage and all the ATLS at the same time. But yes, we have to recheck the endotracheal tube position. We have to recheck the lungs, recheck the hemodynamic status, give fluid resuscitation, repeat the fast, an extended fast. And if the patient recovers from this, we will have to reassess the EGS, that she has an EGS of 3 because of the cardiac arrest, not necessarily from the head injury itself. Well, if she doesn't recover from this, we will have to do the ED thoracotomy. And let's see, if she doesn't recover from the cardiac arrest, it will be very difficult to take her to the CT scan to have the images from the head or any other imaging. Thank you.
Thank you, Dr. Calderon. Dr. Mancia, would you like to comment, sir? Okay, do we have any other comments before we return to Dr. Collet? Okay, back to you, Dr. Collet.
Okay, let's go. I go to this patient. I start with a evaluation, make the ultrasound. There is no cardiac movement. There is no infusion in the peritoneal and no infusion in the pleural cavity. So I decide to go to I go to emergency thoracotomy in the emergency room. So at this moment, I go to share you the movie. You can go to see what's happened, and then you can start this one. Share. Okay. You go to see. We start with anterolateral thoracotomy in this patient. You can see the movie.
Yes.
Yes, okay. You can see the open the chest. Here you can see open the pericardium. The pericardium is very, very difficult to open because it's very thin. You can see there is no movement in the cardiac. And we start to internal massage in this child. You can see here. You have to enough, increase the thoracotomy to facilitate to put the hands inside the chest of the child. You can see here. Open more. I go to put more quickly. You can see the heart. There's no movement. Now we can move more. Problem. And there is a atelectasis of the left lung. The chest tube was removed and replaced. And we have to movement in this movement. Okay. The child in the emergency recovered the cardiac movement. I go to show you here. This was, you can see sometimes the movement comes. And then we decide to transfer the patients to a ward. You can see here. In the ward, the patients during the transportation, when move the surgical table, they have a new cardiac arrest. And this moment, we make a big thoracotomy, maybe to facilitate the approach. It continue to a massage cardiac. During they persist to make the movement. Sometimes he recover, but not sustain the movement of the heart. And here you can see, and she's called start to a fibrillation, ventricular fibrillation. Here you can see there was the fibrillation, internal defibrillation. And the cardiac start to give movements again and sustain the movement. Now the great problem. Can see the size of the heart. The heart being increased during the movement, during the massage and the movement. Here you can see. And start to maintain arterial pressure. You can see now what's happened and what to do. Here going to see the was tying the mammary artery. And what to do with this situation. You can close the thoracotomy again. The heart is too big to close the thoracotomy. Here you can see the heart is movement. And what I decide to do in this moment, you can see you put on warm solutions over the heart, sometimes to make it warm. And we put two drains on the left and the right, and close partially the thoracotomy, and the left side partial open. The great problem, because you can not move. We make a thorax damage or control to the thorax movement at this moment. You can make it open. Close partially. Here you can see. And here you can see I put pads on over the chest, closing the chest, and send the patient stay in the surgical, and then also transfer to the ICU. Okay, but let's go to think here. Stop chair. And this one. Here. Okay. Here you can see the, I go to share again. Sorry. Can see here, can see the blood gas in the emergency room. The first, they make a thoracotomy, internal cardiac, have 4 adrenaline, 2 cardiac defibrillation, amiodarone. In the surgery, during the surgery, she received 1,800 millimeters of saline, 2 packed head cells, 184 millimeters of plasma, cryoprecipitate, and plaquettes apheres. And here you can see the gas after the initial assessment of cardiac arrest in the emergency room. And now you can see the gas blood at the end of the surgery. You can see the patients start to recover the metabolic products during the surgery. What to do with this patient now? She won't go to the emergency room. They go to ICU. You think it important to make a CT at this moment or not? You can go only for the ICU. Okay.
Let's start with Dr. Kasim in Portland.
Oh my goodness, only you can do this, Dr. Collet. You know, the last time something like this happened was a man called Jesus, Lazarus. That's fantastic. That's fantastic. No, you're halfway there now. So you got the patient, at least the cardiac status is stabilized. And I don't think the patient is bleeding because I looked at the hemoglobin, the hematocrit looks good. And the acidosis reasonably corrected. And now you're going to worry about the head. And before you do that, I think I would do an ultrasound of the abdomen to absolutely make sure there's no fluid in the belly, indicating that she may have had injury to the abdominal cavity where she may have lost blood. And I'm still puzzled, you know, how this young girl developed a cardiac arrest. Be that may, you have salvaged this patient. You're halfway there. And I think I would take her to ICU for the time being to stabilize her more. Then I would probably ask my neurosurgical colleague, you know, whether we should do a scan and things like that. I think you just wait it out, see what happens for the next 24 hours. As long as she's not bleeding, you know, you have stopped there was no bleeding and you got the heart going. And I'm still not sure exactly what happened there, but you're there. I'm amazed how good you are. Fantastic. Thank you.
Thank you, Dr. Kasim. Lima, Dr. Calderon, your comments, please.
Great video. Yes. One question, Dr. Collet. Was the thoracotomy performed in the emergency room or the operating room?
Start in the emergency room and then continue in the operating room.
Oh, okay, okay. Well, I don't know what is the configuration in your hospital, but before, well, the patient needs to go to the ICU, but I would make a stop in the CT scan just to know how the head looks like, because maybe she will need a decompression by the neurosurgeon. The neurosurgeon will need the images of the head and the cervical spine. Well, I don't have anything else to add by now.
Okay. Thank you, Dr. Calderon. Let's go to Toronto. Dr. Ali.
Well, you know, Francisco, I was wondering, you gave a fluid. I would have given a fluid as well, but do you think the fluid resuscitation in her had any effect on her coming back? Or was it just the cardiac compression and hemoglobin of blood? And there was no evidence of blood loss anywhere that we could tell, the chest or the abdomen so far. But she seemed to have responded well. Was it from the fluid that she got, or just from the you know, reversal of reasons? But of course, in this trauma situation, you want to rule out fluid, and fluid resuscitation, I think, was appropriate. But I wonder if without any fluid loss or blood loss anywhere else, whether this cardiac arrest was due
Dr. Ali, can you stop your video? Your audio is very jittery.
I don't have any other suggestion as to what to do at this moment. Okay.
Thank you, sir.
Yeah.
Dr. Collet, if you weren't able to hear that, I can get him to send me a chat message and I'll read it out for you. Were you able to hear that, Dr. Collet? Dr. Collet, you're muted.
Okay. I can listen to Dr. Ali. Okay.
Yeah.
Okay.
Were you able to hear, decipher his question, or shall I get it from him?
Okay.
Can you hear me now?
Yes, sir. Go ahead, please.
Yes, I was saying that I'm not sure why the patient responded to the fluid. And if there's no blood loss and any.
Okay, Dr. Ali, I'll work on that from this end. We'll come back to you. That's okay. Meanwhile, let's go to Antigua, Dr. George.
Well, this is an awesome, awesome case, and congratulations, Dr. Collet. You know, I think a long time ago, I was concerned with the time frame to do an EDT, because of course you can recommend it for patients who come in cardiac arrest or pulseless with or without signs of life after blunt injury. So I think it was a brave step to do this to save this young person's life. I'm very interested in the distance from your emergency department to your OT with doing this massage, and any challenges that you may have had transporting the patient to the ER. It looks like it went smoothly enough. I'm thinking that after this patient is now maintaining blood pressures and a pulse post-surgery, if you could get a CT scan brain for head and neck for this patient would be very, very important to decide on your next steps right now. But this case is just very awesome. Congrats.
Thank you, Dr. George. Let's go to Iraq, Dr. Untrack. Your comments, sir?
Yes, I agree that everything was beautifully done up to this point. And, you know, looking at the video, there's been no obvious cause found for the cardiac arrest. And I think the suggestions that have been raised, you know, based on the history that this girl had a Glasgow coma scale of 12 and rapidly fell to 3, and then she went into cardiac arrest. And then the uneven pupils, that suggests that she suffered an acute subdural hematoma, and then possibly herniated the uncus, and that was the cause of the cardiac arrest. So in this case, to save the child, I think it would be imperative to rule that out, and if she has it, then decompress the affected side of the brain as soon as possible. So I would not lose any further time to get that accomplished. Get the CT scan of the head, neck, and if necessary, do the craniotomy. Have the neurosurgeon involved. I think that's urgent because with no other obvious source for the cardiac arrest, that's the most likely source. And time matters here. The longer the delay for an acute subdural hematoma, the less likely the recovery.
Thank you, Dr. Untrack. Can we go to Atlanta, Dr. Frisbee? Your comment, sir?
Well, I think I appreciate all the comments. Calderon's right. You know, I know these neurosurgeons better than anything, and I'll tell you, You call them for help and they'll go, okay, where's the CAT scan? Well, okay, fine. On the way to the ICU, stop by and get one without contrast to the head and neck. And then you can call these guys all you want, because the very first thing they're going to want to know is what's the CT look like. They're not going to operate on anybody without it. So at that point, you know, you can waste a little bit of time later, or you can do it on your way to the ICU. It's just up to you, but you're going to need one. It's just the nature of the beast. But I got to tell you, that was some Jim Dandy surgery. Nice going. Very well done. That's all I got.
Thank you, Dr. Frisbee. Bangkok, Dr. Supo, your comment, sir.
In this case, I agree with trying to get a CT scan of the brain to rule out the intracranial hemorrhage and brain herniation. It's a possible cause of cardiac arrest in this patient. And other than that, I would try to rule out bleeding in other cavities, such as abdomen. I'll try to do fast again at the ICU to check for blood in the abdomen, and I try to get the plain film of the pelvis to rule out pelvic fracture and pelvic hemorrhage, because those are possible causes of bleeding for this patient too. And other cause of cardiac arrest in this patient that nobody mentioned yet is fat embolism. If she has a fracture of the long bone, fat emboli may explain the cardiac arrest in this patient besides the severe head injury. But there's no specific treatment for that. So at this point, get the CT scan, get the neurosurgeon involved, and rule out bleeding in other cavities. Thank you.
Thank you, sir. Boston, Dr. Oyman, my apologies, sir. Thank you for joining us. Did not see you there.
I'm sorry I joined late. So despite many people quoting me as saying, I don't know what I'm talking about, but I still have an opinion, this time I will refrain for giving my opinion. Thank you.
Okay. Thank you, Dr. Oyman. With that, any other comments before we return to Dr. Collet?
I have a question.
Go ahead, Dr. Casino. Yes, sir.
Would anybody do a burr hole without sending the patient to the CT scanner? No.
Nobody?
Yeah, no. If I can just comment, it depends on the setting, you know. And I've been in situations. I know one time in Haiti where a patient came in and had a typical course for an epidural hematoma. So an injury, a lucid interval, and then he vomited and became unconscious and had a dilated pupil on the left side. And I was called at that point. We did a burr hole, and he woke up the next day. So if you don't have access to a CAT scan, you need to use the physical exam. And in fact, in one site where I've been in this country, there was no CAT scan, but we still ordered a burr hole kit. We got a burr hole kit on site in case there was head trauma, and you can use the physical examination and the course. But I'm sure Dr. Collet, I know he's got a CT scan there, and I would certainly do one. Or if things were going to be delayed and you couldn't move, in this case, given everything he's mentioned, to do a burr hole in the ICU, when he opened the chest and the ER and got such a good result, I would do a temporal burr hole on the side of the dilated pupil if he could not get immediate access to a CAT scan, or if he couldn't transfer her for whatever reason. But I think the issue is not to delay, to get it done as quickly as possible.
Thank you, Dr. Umchak. Anyone else? Everyone have an opportunity to comment before we go back to Dr. Collet? Okay, back to you, Dr. Collet. Thank you.
Okay. In this situation, I agree with the comments. The patients go to stay in the surgery, and during the post-operative times to transfer, the patients continue to maintain hemodynamically stable using drugs, articulate drugs, but she's stable. So we decide to make a CT and then go to the ICU. So I go to share the CT. You can see here the CT. Let's go to show you. It's an angio CT. You can see this scan. There is no fractures of the skull. There is no mass on the skull, but you can see edema. There is on the brain. There is no. Can see the ventricle is very in the middle. There is no movement there, and can go to the cranium. It has only edema. It's very big edema on the brain, and there is no other findings in the CT. In the CT, you can go to the chest. Can see here. Go to the chest. There is only the surgeries move do. Can see the big heart. Can see a telectasy of the left lung partially. Can see the chest tubes correctly positioned. And in the abdomen, you can see fluid, but the density of the fluid is not blood. In the abdomen, there is some fluid, but because you can see the patients during the surgery have received too much saline, you can see fluids maybe in the abdomen. So the patients continue to be stable, and so I decide at this moment not to put the patients again to the OR and send to the ICU. And and wait for this neurosurgeon evaluation. Here, share this one, and just a minute. I go to share. Okay, you can see here the angio CT, and the patient went to ICU. During the ICU, she was in mechanical ventilation. Respiratory rate was 24 EPM. Saturation is 100%. Concentration of oxygen was 50%, and the PEEP pressure, expiratory pressure is 6. Murmurous vesicular present. Blood pressure is 142 by 90 millimeters of mercury. Cardiac rate 150 BPM. Fast is negative. Glasgow comes CT, and the neurosurgeon evaluation, they place a monitor of the pressure, brain pressure, and a cerebral ventricular external drainage. And the pressure at this moment was 6 in them, and the brain pressure variation between at this moment 15 to 18. Yes, he put a tube in the patient. And what to do in this moment. And on the second post-operative day, you can see the gas blood, they be corrected again, and the patient may become stable. So we decided to put this patient again to the to surgery to close the chest, to close the chest. Now I go to show you what, okay, share this one. Here you can see the patient on the second post-operative day. You go to see here. You can see the monitor in the surgery. You can see the saturation, oxygen saturation, blood pressure. Okay, here. And then I go to show the patient.
Dr. Collet, were you sharing?
Can share or not, Sherry? Can see or not?
No, sir, it's not sharing.
Okay, I go to share the screen. Oh, sorry. Okay, can see here?
Yes, sir.
Okay, can see the monitor here, can see the blood pressure and the saturation, oxygen saturation in the surgery. Now, I go to show you the patient. Here you can see the patient. The chest damage control, only can see the bandage. the two tubes. I go to show, you can see in the here in the a catheter I put in the saphenous vein, a very large catheter to make go to the reposition. Is usually I put sometimes here. You can see here the chest. I go to show the thing what's happened with the heart. I open the dressing. Now you can see here the chest open, and here you can see the heart. You go to see the heart movement through the chest wall. The edema decrease, and now you can close the chest. Here you can see. And now I close the chest. Okay. You can see here, you can tell me what to do more in these patients for this position, because the problem was going to increase the problem, and sometimes very difficult to resolve. Okay. In this situation, Gary, they can okay, they can comment what to do, what think about in these patients now. The patients continue to be stable, and what to do with this patient now.
Yes, sir. Atlanta, Dr. Frisbee, your comments, please.
Well, you've got the chest closed. Is the patient stable?
Yes, the patient continue to be stable.
I think I would have a little patience. Wait. Let's see. If the neurosurgeons have punted on this one, then I think I wouldn't just get in a hurry to take her out of the ICU. I would wait 48 hours, see what happens. I would not be in a hurry to dispose of this case. Let's just wait. That's my only opinion.
Thank you, Dr. Frisbee. Bangkok, Dr. Supa.
I agree with Dr. Frisbee. At this point, we made her stabilize hemodynamically, and I think that was amazing for this patient. Now, I think she needs some time for her brain to recover, and because neurosurgeon put in the ICP monitoring in this patient, I think that means they haven't given up on this patient yet. So they have something to look for. They have ICP monitoring, and I think she needs time to recover. So at this point, just keep her in the ICU and try to feed her some nutrition when she's ready, and wait and pray. Thank you.
Thank you, Dr. Supa. Iraq, Dr. Untrak, your comments, sir.
Yes, I think that's very good news that the CT scan showed only edema. That suggests that this girl should have a good prognosis, better than if you found an epidural or subdural hematoma and then had to do a thoracotomy after several hours. So, and I agree with Dr. Frisbee and Dr. Supa that you want to give her a chance to get better, let the edema subside, although the intracranial pressure was, I think, in good range, 15. About the fluid in the abdomen, Dr. Collet said it was not blood. I think the other possibility after the resuscitation, presumably that fluid was not there when she came in because it would have been seen on the fast. The other possibility is a bladder rupture. So I assume that she has a Foley catheter and she has good urine output. Otherwise, I would try to assess as to whether she might have a bladder rupture. You can do a paracentesis and check for urea nitrogen, or a little contrast material in the bladder and do a plain film of the abdomen. But that would be the other thing to take care of. Find the cause of the fluid. It might just be simple edema, although it seems like a lot. I would rule out a bladder rupture unless it's obvious that you have one because your urine output's good. And then I'd be concerned about the pupils at this point. But otherwise, I would simply keep her on the supportive treatment. let her wake up and be optimistic for a good result.
Thank you, Dr. Ontrack. And we go to Antigua. Dr. George, your comments, ma'am?
Yes, I think the open chest management here, the delayed closure here was very, very good. And just as we waited for with this edematous heart, I think we can wait a while for the brain to settle down and not be in a hurry. I'm not too concerned about the fluid in the abdomen. If you say that she's stable, I'm sure she already has a catheter in and all that since the day she came in. So I'll wait right now, and children usually bounce back after we've done all these things to them. So I'll still wait.
Thank you, Dr. George. Lima, Dr. Calderon.
Yes, so far this little girl is receiving what she needs: the respiratory support, the osmotherapy for the brain edema. I don't know if it was done with only mannitol or hypertonics. Well, she was rescheduled for the re-exploration of the chest and the formal chest wall closure. Well, we can still monitoring her in the ICU, giving the respiratory support, reassessment of the hemodynamic status. If possible, stop sometimes once a data sedation to make neurologic reassessments. And in the abdomen, it looks like only fluid secondary to the over-resuscitation, to fluid overload, sorry. But we will need to check how is the intra-abdominal pressure. Yeah. And that's it by now. Nicely done.
Thank you, sir. Can we go to Toronto, Dr. Ali? Go ahead, Dr. Ali.
Yeah, I have nothing to add right now. I think her hemodynamics appear to be okay. Her blood gases were, she was acidotic initially. She's improved that. So her perfusion looks okay. Her blood pressure is okay. And the brain is still quite tight. I'm not sure if she's not, her pupils, I don't understand why her one pupil was dilated to begin with, and she didn't have a mass detected on the CT scan. A bit surprising about that. But if her neurologic status is not improving, there might be some room in presence of a tight brain with cerebral edema to, well, of course, first of all, restrict her fluid, but maybe trying to decrease the cerebral edema by, but certainly nothing, and continue to observe her to see if she gives us any indication as to whether something else is going on that requires our attention.
Thank you, Dr. Ali. Dr. Kasim, your comments, please.
Well, earlier on, I said that you were halfway there. Now you're about 3/4 of the way there, and now you need to exercise patience. In my opinion, this patient was run over by a motorcycle, and I think she sustained a blunt cardiac injury, probably had electrical malfunction, and went into cardiac arrest and caused all this problem. You don't have to look for any other reason to do something to her other than be patient. And I think somebody mentioned that you may want to deploy mannitol. There's no harm in doing that. Decadrone, you can do that too. And I think this neurosurgeons have done their part, and they are watching the ICP. And now she needs to tell you that the brain is working good because the heart has been stabilized through a miraculous treatment by Dr. Collet. I'm absolutely flabbergasted. What a nice case. Thank you.
Thank you, sir. Dr. Oyman, are you, would you like to comment, sir?
Even though I don't know what I'm talking about, maybe. I really don't. The CT scan of the abdomen, it was very characteristic for something that we call shock bowel. I think that this patient was in shock, probably cardiogenic shock in this case. And after the resuscitation, it's not that she's overly resuscitated, the tissue start leaking. The sodium potassium ATPase stop working. There's not enough ATP, and you get cellular edema, and the capillaries leak. So that's the reason that is so clearly seen, the edema and the mucosa in the bowel and in the stomach, and the free fluid in the abdomen. That, as Dr. Calderon mentioned before, put her at risk for developing abdominal compartment syndrome. But the same thing that happened in the abdomen probably happened to the brain. It was a state of shock, and after that develops edema. Here we will use hypertonic signaling. The other possibility with the brain, depending on the degree of trauma, is the diffuse axonal injury that's usually not seen in the CT scan, and would require an MRI, and only time will tell how well she can recover. But again, kids usually recover very well. They have too much reserve. But those are the only comments. I will be concerned about the development of abdominal compartment syndrome, and I will be very liberal with hypertonic saline for the brain edema. Thank you.
Thank you, Dr. Hoyman. Okay, before we return to Dr. Collet, let's check with Dr. Altman to see if he is prepared to comment, or would you just like to continue to observe?
No, I don't have any comment, so let's go on.
Okay, thank you very much. Any other comments before we return to Dr. Collet? Okay, back to you, Dr. Collet.
Okay, I go to show what's happened with the child, because the great problem with the child was a brain. So the patients continue extremely severe sign development, intracranial hypertension, refractory to admissions, a care barbiturate coma. On the 6th post-operative day, the ICU increased the value above the 17 millimeters of mercury. And despite the near-product admission, the patient present irreversible cardiac arrest on the 6th post-operative day. So I present the case because it's very difficult to think about to do emergent thoracotomy in blood trauma, but sometimes can happen, it can recover the patients, but the injuries that the patient has is very difficult to recover. So in this problem is great problem is the problem with the brain injury. So I thank you for to listen and to give the comments, and I want to know the final comments of all of us of yours. Your all final comments. Thank you.
Thank you, sir. Dr. Kasim, your final comments, please.
Oh, that's sad. Sometimes you lose when you are doing so well. Well, I learned a lot. Thank you so much for sharing this case, even though it didn't go very well at the end. But sometimes you lose. Most of the time you can win. Sometimes when you lose, then you shed a tear, and then you look for the next case to salvage. Dr. Collet, you truly are a master surgeon. Thank you.
Thank you.
Thank you, Dr. Kasim. Dr. Untrak in Iraq, your final comments, please.
Yes, a little sad and disappointing. We've all been there, and you know, I compare this case to the that boy in Israel in the back of the car that we were all amazed that he recovered at the end, and that child had diffuse cerebral edema also, and he benefited from the craniectomy. So, but you know, you had your neurosurgeon on the case, and apparently he didn't feel that would have been beneficial, but it's unfortunate. But yeah, I think you did everything that was reasonable, and all your efforts, I think, will help the next patient that comes through injured like this. But well done, and little sad about the outcome, but you did your best.
Thank you, sir. Atlanta, Dr. I'm sorry, go ahead. Let me just take care of this. Dr. Mancia, would you like to make a comment? Okay, let's move on to Lima, Dr. Calderon.
Well, as far as I remember from my neurosurgery lessons with neurosurgeons, in the 6th or 7th day of trauma, there is a second peak of intracranial, increase in the intracranial pressure. So maybe that's what's happened with this little girl. With an ICP of 70, it's very difficult that the compressive craniotomy saves her. It's going to be very difficult. Well, I don't know if the neurosurgeon considered that decompression of the head, but it's very difficult to save her with that. She developed a malignant intracranial hypertension. So you just did what you could. That's what happened with little girl. Well, I'm sorry we lost her, but our job was done. Well, thank you and good day. Good. I learned a lot.
Thank you, Dr. Calderon. Can we go to Antigua, Dr. George?
This was a very good case. Congratulations, Dr. Collet. Very sorry that in the end she didn't survive, but I'm sure it's prepared us all for the next patients who may need this, you know. And now I have a lot more energy after seeing this case. Thank you so much for sharing.
Thank you for your comments, Dr. George. Let's go to Toronto, Dr. Ali.
Well, this was a very exciting case, and unfortunately, the end didn't please us very well. But I think Dr. Collet has to be congratulated for trying his utmost to save this young child. I think we should try to be as aggressive as possible in the young ones. We almost got her back, but I think in the end it looks like the fetal edema is what the kids can have cardiac arrest for very obscure reasons, and I think the early thoracotomy was the best thing we could have done. Too bad the outcome was as it is. Was there a postmortem? Was there a postmortem?
Dr. Collet, question for you, sir. You're muted, Dr. Collet.
Yes, I don't listen to the question.
Was there a postmortem? Postmortem.
Postmortem. Let's go to the. I don't have the relator of the pathologist of the postmortem, because there is problem here from they don't send to us the relator of the necropsies.
Okay. Does that satisfy your question, Dr. Ali? Okay.
Okay, thank you. Nothing further.
Okay. Thank you, sir. Dr. Frisbee, your final comments, please.
Well, I only have two things. Of course, it was a tremendously great case. It was just tremendous. You know, the ancient Romans used to think that good luck.
Oh, I'm sorry, Dr. Frisbee. Go back and say good luck. You froze right there.
Oh, I did.
Yeah.
Oh, sorry.
Hate to miss that.
Oh, well, good luck and good fortune always is carried on your shoulders. That's why people in the Roman world used to want to just come in contact with somebody who had good fortune. Makes me want to get on a plane and shake your hand. It's just very well done, extremely well done. I'm sorry about the outcome, but that is not why we do this. We have to do this with the best intention. Sometimes it just doesn't work out, but very well done. Thank you.
Thank you, Dr. Frisbee. Bangkok, Dr. Super, your final comments, please.
Thank you very much to the colleague for presenting this interesting case and very well managed. And thank you very much for not giving up on this patient till the end. Thank you very much.
Thank you, Dr. Super. Dr. Wayman, Boston, your final comments, sir?
I think that by the time this patient reached Dr. Collet, probably her case was too far gone in terms of the brain edema. The reason for the brain edema most likely was hypoxia, and this is kind of what we see in severe hypoxic brain injury. One thing to consider is that this is from a theoretical standpoint, because this is an educational conference, is that this patient was at risk of developing abdominal compartment syndrome. Even if it's not the full-fledged abdominal compartment syndrome, high intra-abdominal pressure. High intra-abdominal pressure has been described as one of the side effects is this increased intracranial pressure. As a matter of fact, there are series where they treat refractory intracranial pressure by decompression laparotomy. So this is something just to keep in the armamentarium for patients that we are facing with a refractory intracranial pressure that we suspect, even though they might still be making urine and they might not have signs of respiratory compromise, the increase in abdominal pressure might be enough to cause problems with the intracranial pressure. Having said that, I think this patient probably had injuries were in the brain were present before she reached Dr. Collet. An excellent case. As always, I tell my residents that when Dr. Collet is speaking, they should listen, and this prove the case. Thank you.
Thank you, Dr. Lemon. Any additional comments?
I would like to comment. It was very well managed by Dr. Collet, but this case represents most of the blunt cardiac arrests. And just to mention that 5% of the blunt cardiac arrests will survive, and most of them will have very severe disabilities. So I think this is very representative of the cardiac arrest in blunt trauma.
Thank you, Dr. Altman. Any final comments before we wrap up? Thank you, Dr. Collet, for presenting the case, and thanks to everyone for joining us. We'll look forward to seeing you again next Monday. In the meantime, please take good care of yourselves.
Bye.
Thank you, everyone.
Bye.